Welcome to the fifth hearing of the Public Accountability Committee's inquiry into the government's management of the COVID-19 pandemic.
I'm outraged.
The inquiry is intended to provide ongoing parliamentary oversight to the government's response to the unfolding pandemic. Before I commence, I'd like to acknowledge the Gadigal people, who are the traditional custodians of this land, and pay my respects and those of the committee and the witnesses to those elders past, present and emerging, and extend that respect to other Aboriginals present. Today we will hear evidence from witnesses from the mental health portfolio in the morning, including the Minister for Mental Health, Regional Youth and Women, and from the Better Regulation and Innovation portfolio in the afternoon. The COVID-19 crisis has touched our lives in nearly every way. While primarily a public health emergency, the massive social and economic disruptions the pandemic has wrought plays out in more subtle and insidious ways in the mental health and well-being of our communities. Public policy and health interventions must therefore look beyond narrow definitions of physical health in order to address far-reaching impacts on people's mental health and well-being, especially the most vulnerable and disadvantaged in our community. In times of crisis, it is incumbent upon governments to provide additional support for individuals and families experiencing psychological distress, however this may be manifested. Indeed, some of the most vulnerable in our community at this time are those who rent. With many people being stood down, losing their jobs or having their income cut, renters are facing many uncertainties and pressures, especially with the prospect of income support schemes such as JobKeeper being abolished or discontinued in the near future. The government's policy response to these issues is a matter of significant public interest. These are matters that will be considered at today's hearing. I would now like to make some brief comments about the procedures for today's hearing. Today's hearing is being broadcast live via the Parliament's website. A transcript of today's hearing will be placed on the committee's website when it becomes available. In accordance with the broadcasting guidelines, while members of the media may film or record committee members and witnesses, people in the public gallery should not be the primary focus of any filming or photography. I would also remind media representatives you must take responsibility for what you publish about the committee's proceedings. It is important to remember that parliamentary privilege does not apply to what witnesses may say outside of their evidence at the hearing, and so I urge witnesses to be careful about any comments you make to the media or to others after you complete your evidence, as such comments will not be protected by parliamentary privilege. The guidelines for the broadcast of proceedings are available from the Secretariat. All witnesses have a right to procedural fairness in accordance with the Procedural Fairness Resolution adopted by the House in 2018.
Hear, hear.
Minister, there may be some questions that a witness could only answer if they had more time or with certain documents to hand. In these circumstances, witnesses are advised that they can take a question on notice and provide an answer within 21 days. I remind everyone here today that committee hearings are not intended to provide a forum for people to make adverse reflection about others under the protection of parliamentary privilege. I therefore request that witnesses focus on the issues raised by the terms of inquiry and avoid naming individuals unnecessarily. Witnesses are advised that any messages should be delivered to committee members through the committee staff. And to aid of audibility of this hearing, may I remind both committee members and witnesses to speak into the microphones. The room is fitted with induction loops compatible with hearing aid systems that have telecoil receivers. In addition, several seats are reserved near the loudspeakers for persons in the public gallery who have hearing difficulties. All witnesses from departments, statutory bodies or corporations will be sworn prior to giving evidence. Minister, I remind you, you do not need to take an oath or an affirmation, as you have already sworn an oath in your office as a Member of Parliament. For all other witnesses, and starting with you, Mr. Pearce, could I ask that you please state your full name, position, title and agency, and then take either an oath or an affirmation, the words of both of which should be in front of you.
Full name, David Wayne Pearce, Executive Director, Mental Health Branch, New South Wales Health. And the oath, I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thanks, Mr. Pearce. Dr. Wright.
So I'm Dr. John Murray Wright, Chief Psychiatrist, and I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thanks, Doctor. Minister, thanks for attending today. There's now the opportunity, if you wish to take it, to make a brief opening statement.
Ms Shoebridge, I'm happy to make a statement. Would you just all prefer to start asking me questions? What's been the process so far?
Minister, brief statements have been made before, so that might be a useful introduction.
Okay, thank you, Mr Shoebridge, and thank you for having me here today to the committee and to talk about such a such an incredible time in our history during the period of COVID-19. There's been many challenges, many things written about the potential mental health impacts and the real mental health impacts in terms of COVID. I think the state has seen quite an unprecedented time in 2020. I shouldn't say unprecedented, we're trying not to say that word. In terms of the fact that we've had drought, we've had bushfire, and now we've got COVID. Look, I'm really proud as the Minister for Mental Health that we've been able to implement a $73 million injection into the mental health system. And in addition to that, which brings it actually to 79, was $6 million for Lifeline as well. We know that calls have increased to Lifeline, so it's been really great that we're able to preempt that with the investment to increase the capacity. We've had some really great programs in terms of the $73 million that we announced. And I'd be really happy to elaborate on those further during the hearing. We've had terrific responses with our PACER program. We've had terrific responses with the fact that we're going to put 180 new mental health expert clinicians into the field in terms of primary health care. That's 180 plus 36 will bring that to 216, including the PACER clinicians that will be going out as well. That's a massive injection into our mental health services. I'm particularly looking forward to the evaluation on our virtual mental health teams. I think being able to put one virtual mental health team into every single LHD is really good. It's something I feel really strongly about, being someone who lives in a rural community. I think it's great to be able to look at different ways of providing services, and I think that's actually one opportunity that COVID has actually provided to us. It's actually provided us the ability to see how we might be able to do things differently and implement that. We've also, of course, already had going our suicide prevention strategy, and that actually I'm really hopeful is going to see some good results, and the timeliness of it was really paramount in terms of heading into this period where we've had so many external stressors on people. Things like our pop-up services, our alternatives to the emergency department, I think those things are going to make a real difference. But you know, I'm not the sort of person too that I'm going to say it's going to be one fix that'll fix all, but I'm really pleased we've been able to make the investment to increase the capacity, and I'm going to look forward to seeing how these things work and how they help people that are living with a mental illness. I think one thing I'd like to say, Mr. Shoebridge, in concluding my opening statement, is that the way that some of us have been feeling lately during the drought, during bushfires, or during COVID-19 is often how people with a mental health illness feel every single day of their lives. You know, that feeling where they don't want to get up in the morning, or that feeling where everything's spinning so fast around that you can't break free out of that circle. And so I think it has allowed us, and I would like to think that it has allowed us the opportunity to think about how those people feel every day and to actually have more empathy and more ability to say that we need to do more and we can do more.
Yep, thank you, Minister. It has been a dreadful year in many ways, and thank you for the opening comments. I'll pass now to the opposition.
Thank you, Minister, and thank you for the opening comments. It's a good, broad overview of some of the announcements that have been made. But can you just take us through some of the specific details within that sort of bucket of money that you refer to that are related specifically to the pandemic? So the programs that have been put in place, or what out of the 73 million in terms of the injection, as you describe it, into the mental health system is related to COVID?
Yeah, sure. I'd love the opportunity to do that. Thank you very much. So I suppose we'll just start with enhancing the mental health line. So that's the 1-800 mental health number. So in any health system, and I know that you would know this, but the really most important thing is that access point. Is that access point to get into the system, to then be triaged, so then be referred off to where you need to go. That's what our mental health line does. We predicted that there would be increased capacity in terms of need for mental health services during the COVID-19 pandemic. So we knew that we had to get that part of the service really robust and really firing. So by making that additional investment into the mental health line, we are allowing it the capacity to pick up approximately an extra 60,000 calls. So that was something that we really, really needed to do, because we needed to make sure that that capacity was there within the system. The virtual mental health expansion to all local health districts. Well, living in a rural community, we know how important it is to have access to the right service at the right time, and we know often that we don't have the same capacity to recruit. We know we don't have the same capacity in terms of the number of health workers that are working in some of those communities. So the ability to do virtual mental health care is a really exciting development and a really exciting space, I think. And what I mean by that too is it's not, often we've come such a long way. Like, I know when I first talked about telehealth, it was very different in my nursing context to now talking about virtual mental health services. So the ability to have these virtual mental health teams, so there's specific people actually working on those teams within the LHD, and that's their sole focus and their job, to make sure that they do that virtual mental health. But it's not only about making sure that the people that need the service have access to it in a timely manner, but what it actually provides is educational opportunities for our clinicians and for people delivering the service. Because there's nothing better as a clinician than when you're able to talk with other clinicians, you're able to look at different models of care, you're able to see how it might work in one community and then how you can fix that to work in your own community, because there's no way that one size fits all, and that's a really big mistake that people sometimes make in thinking that. And we've seen that, and Dr. Wright and I were only actually discussing that this morning when he was the mental health director for Southern New South Wales, when people decide that, something that's worked in the city is going to work really well in the country, and it's a big mistake to make that doesn't get good outcomes. So we're able to be really flexible. Mr. Pearce, who can also elaborate as well, has also been a mental health director and is now head of my branch. This is his first hearing today, so I'm very pleased that he's here with us. But he has first-hand experience of that as well. So I think that being able to actually provide educational opportunities to clinicians will only embed their expertise, give them more confidence in their practice, and end up having better outcomes for our people that require mental health services. Obviously also supporting first responders in the PACER program. So that was a trial that was rolled out in Covert, and it's had really incredible results, and we're really pleased with it. It's had over a 10% decrease in people presenting to emergency departments. It's had I think 14% decrease in police scheduling under their S22, I think it is. So that's been really, really important, and the two clinicians that have pioneered that, Fiona and Felicity out at Covert, have been champions, and the police officers out there, the way that the respect when they speak about these two women and the incredible impact that they've had in there. So again, we predicted that we would have, when the modelling showed potentially what the worst outcomes of the pandemic could bring, we knew that we had to do something in terms of, first responders doing things. So that was really good. And that's that program. We also specifically brought in enhancing divisional therapy activities in acute units, and that came directly out of the COVID response. And what we had to do, and what Dr. Wright had to do as the lead for psychiatry services in New South Wales, was some really tough decisions had to be made in terms of our mental health inpatient units. And that decision that came to in agreement with all mental health directors and Dr. Wright was that leave would have to be cancelled during this pandemic time to protect the people that were in there and protect the services. So by doing that, we knew potentially, okay, so if that's going to happen and people can't have leave, what are the potential issues that are going to face us with that? And that was that people would become frustrated, that it would actually be more difficult on our mental health clinicians and our staff. So we actually put in money into every single inpatient mental health unit for diversional therapy. So, and that can be different things to different people. So in some units, they might have wanted to do more lifestyle, life skill courses like cooking, or some other places might have wanted to do art, some other people might have wanted to do other types of diversional therapy, so that's allowing the opportunity for that. We also...
Minister.
Yes?
You have to allow the second question.
Oh, I'm sorry, Mr.
I know.
Schubert,
I think your enthusiasm is
Enthusiastic.
extraordinary, and I'm not trying to cut you off, but I think there's probably some. We might go through some of these things just sort of more thematically because but I'll let you wrap up. But I think there's probably going to be some.
I can't, I've got it, the question,
You go.
and correct me if I'm wrong, but the question was,
It was
what
a very
are the
broad
programs that
question.
you, so I'm
Correct.
just trying to answer the question.
There is a point to
it.
it though, and
what-
the actual question was broad, but there was a specific part of it, which is where I want to get to is what is specifically related to COVID.
So as I
So-
just said, in the diversional therapy, which is exactly what I said with the increased capacity of the mental health line that we're expecting extra calls, so we bumped it up. And I also said with the virtual mental health expansion that we know that we need to look at different ways of doing things when we can't see people face to face. So I think I did directly answer that.
Oh, and Minister, I'm not suggesting your answers weren't relevant.
But I'm happy to keep going on all the other initiatives and how they relate to COVID, as the question asked me to do.
No, we're going to go through each one of those. Don't worry about that. So that's fine.
No,
You'll get to
I'm
talk about each
excited.
one more specifically. But happy to get the broad.
Would you like me
outline
to
because-
finish all of the things with the question that you asked?
I'm happy to jump in. There's been it's directly relevant. This is an inquiry specifically about COVID and the response of the government in relation to the pandemic. So there have been a number of announcements and a lot of dollar amounts thrown around in terms of mental health. And I'm interested in understanding more broadly today what money is specifically related to this pandemic and what money would have been spent otherwise. But particularly, some of these programs, we'll go through each one of them, but won't necessarily relate to COVID. So I'm interested in what the timeline for these programs are. So, for example, we can start with PACER, because that's the topic of this week. That's fine. I note that the money for the program, which has only been rolled out in Sydney, so not regional New South Wales, has been reported as coming out of the money that the government have announced for COVID-related funding. Can you explain how it relates to COVID? What's the time period this is going to be in place? Is it in the longer term going to come out of mental health funding or police funding? So how does that work? It seems like a more broader program than just COVID-related.
I would have thought
COVID
that
money.
any program that enhances mental health services is a really good thing. But anyway, I'll answer your question, and also I
Criticism of the
must
program is
correct
questions
you
about
in the
where the money's
fact
coming
that
from.
you have said, and I understand you put out something yesterday about it not being in rural and regional areas, and that's actually incorrect. No, you're actually wrong. And I'm sorry, but that's actually the truth.
Well, Minister, now is your opportunity to explain that.
Yes, Mr. Schubert, and I'm very happy to do that.
Which areas it's been rolled in?
Yeah, I will.
Rolled out in outside of Sydney.
Let me answer the question. So this morning, actually, I was on the radio in the Illawarra because there were comments made about how there were no services down there in relation to this pilot program. So there's actually been a trial running in that area since April. Right? So we've actually been doing that in conjunction with the Illawarra to look at how we could do things. And so to say that it's not existing is incorrect. So we just need to. Well, so what we've done is we've done the proof of concept for the mental health ambulance and police project as well, which is the same.
About PACER, so it's a
Yeah,
specific
but
question about the
PACER.
PACE program, which
Well,
you announced this week.
point of
Oh,
order.
dear.
Yep.
The Minister seems to be being directly relevant.
I accept your point of order. I think the Minister needs to be allowed to finish.
Thank you, Mr. Shoebridge. So just to tell you the absolute facts and the actual numbers on that, it's resulted in 16 calls from police for potential community assessments, 14 consumers have been assessed in the community by mental health clinicians, and 7 admissions to the Wollongong ED have been avoided. So that's one program. And then I understand as well yesterday that one of the local members came out and said that there was nothing happening in Western New South Wales. Well, that's also incorrect. There's a trial that's ready to go in Western New South Wales to actually pull out to Cowra that was due to start in January, but because of COVID had to be pulled back at that time. So, I think we need to be... Well, that particular one, no, but we've been working on this pilot for quite some time. What we knew with COVID and with the pandemic was that we potentially would have an increased number of people being very distressed. And when people become very distressed and they have a mental health issue, they can have difficult situations in the community. So what it's allowed us to do is to roll out a program where we've done a trial and we've announced that. And then that we didn't announce the trial, we've announced the pilot, which is across metropolitan Sydney. This was solely developed for metropolitan Sydney. You can't take the worst thing you can do in health. The worst thing is you can take something that suits a metropolitan area and just say, this is how you're going to do it in a country area. It doesn't work. We all know that. So this is about the fact that we're working on these things all the time.
But Minister, with respect, sorry,
like
just back to the question, you've just accused me of putting out a statement yesterday that was wrong because you're saying that the program is not only based in Sydney. Your announcement, the announcement that came from your and the Police Minister's office was that this has been rolled out in police districts in Sydney only, and that at some future point you might look at it in regional New South Wales, and now you're telling me that there is a program in regional New South Wales?
No, I'm actually telling you that you are incorrect.
Then can you give us
You
the
are
details?
incorrect.
Well, can I just take a point of order, really directed at
Well, I think, can
both sides?
I suggest this works best where we have question and answer, not bouncing back and forth. But I understand why it's bouncing back and forth, because I think I think it's with you, Minister, to explain, given the announcement yesterday, and the announcement said that the program will operate in Campbelltown, Nepean, Northern Beaches, Sutherland Shire, Blacktown, Eastern Beaches, Ku-ring-gai, Metro combined, which is Kings Cross, Surrey Hills, City of Sydney, South Sydney and Bankstown Police. Given that was the announcement yesterday, I think it's reasonable to expect some clarity about, given the announcement only mentioned metro regions.
Yes.
I think it's fair to ask, and
Sure, Mr.
the
Chief
members trying to understand if PACER is outside of that list that was provided yesterday.
And I'm very happy to answer that. What we're announcing was the metro expansion of the PACER program in relation to COVID. When you want to find out about what's happening in local areas, it's really helpful if you want to ring the local mental health director. Now, if you rang the local mental health director in Western New South Wales, who's based in Orange, they would tell you that we've all been looking at this program because the results initially are extremely exciting for us in the mental health space, extremely exciting. And that's what's been happening in the metro area. So of course people are watching things and looking at that all the time. That was a trial that's now become a pilot program across metropolitan New South Wales. But that also is the fact that there will be 2 regional trials, and they will be announced in time. But the reality is that already at the moment this is going on. And if people actually just checked and just inquired and talked to people on the ground in those local communities, they would know that.
So, Minister, with respect, that's kind of what we're doing here. It's an inquiry into
Well,
what the
it's not
government
what
is doing in relation to COVID.
With respect,
There's
it's
no
not
need to
what
be
you did
offended by my
yesterday.
questions. I'm asking questions. That's my job here.
I think the point of order is already well made. This isn't about everybody trying to explain their position one way or another. It's about questions and answers, and I think I'd ask both the Honourable Tara Moriarty and the Minister to try and respect that process, because it's easiest.
Sure.
On both hands. So
I'm happy to accept that.
I'm handing over to you for a question.
Sure, very happy to accept that. Genuinely, actually not trying to argue with the Minister. This is my question. So I've asked a question in relation to this program. So far, the answer has been that the program is outside of Sydney, and the answer has been that it's not yet outside of Sydney, but people are looking at it. So where is the program operating outside of the announcement that was made by you and your fellow minister yesterday or Wednesday?
What a great announcement. As I said to you before in your previous question and my previous answer to you, which I'm sure Hansard will reflect, I spoke about 2 trials that are undergoing at the moment. They're not pilots, they're trials. So we're trialling them. We're trialling to see how they're working, how we can do things differently. So if you look at Cogra, where it started, and you look at the local area command, they have 3 police stations within that local area command. So 2 clinicians, Fiona and Felicity, that are based there that cover that area. If you look at something in Western New South Wales, take the Chifley Local Area Command, there's over 20 police stations in that area. So if we had 2 clinicians seen in one place, if we put them out at Cadal, for example, they might have one call out every fortnight or every month. So we've got to look at how we can do that differently, and that's exactly what we'll be trialling. It's not a pilot yet. It's a trial.
Not happening
But to
yet.
say it is happening.
I'll take the point of
But
order again.
I'm not getting an answer
One-
to my question.
No, you're not here to
One
argue.
is not
I like the
entitled
answer.
to make editorial comment as the minister
I'm
is
actually trying to get an
answering.
answer to my
Sorry,
question.
but I do think I do think if we all show we've got plenty of time this morning.
Yeah.
So let's just and Minister, I'd ask you to, as best as possible, be directly relevant to the question, and I think you're endeavouring to do that. We've got plenty of time. We'll let the answers conclude, and then you can have your follow-up. And I think it's quite legitimate. You're wanting to have a follow-up, but let the answer conclude and then do the follow-up.
So
Minister, ball's in your court if you
yes,
wanted to
Mr.
finish the
Shoebridge,
answer.
and respect, I feel I can't be any more directly relevant than say that we're trialling that in this area. I actually talked about the numbers of people already that have been seen, and I can't be more directly relevant to say that we are ready to go with a trial in Western New South Wales, and that site will be Cowra. Mr. Pearce may like to elaborate on that for you, but those are the facts and those are the numbers. So, Mr. Pearce, would you like to?
Well, no, but
elaborate
can I
further?
just...
Well, I think
my
the minister's
question-
allowed. Well, we'll hear what Mr. Pearce has to say, and then we will come back to you.
Let's just, I'll just sit back and
We'll come
wait
back
for
to you,
this
Tara.
so I can't
I
get
think you
question
sit back and wait for the answer.
Go for it.
I'd be happy perhaps to provide a bit of context to answer the question. So in this $73 million package, there is funding across the state to support first responders, ambulance and police. There's a particular model that predates COVID, the PACER model, which was trialled in Covert, which showed great success and enthusiastic support by police. So the Minister has announced that model for Metro Sydney. In terms of the broader theme of support for first responders, police and ambulance, the point the Minister was making is there are various models which are more applicable in regional and rural than the model that was applied to Metro. The reason for the particular approach in Metro of embedding mental health clinicians in a police station is small geography, large volume of call-outs, so those positions are effectively utilised based working with the police. In rural and regional New South Wales, that certainly isn't always the case. As the Minister made the point, there's multiple police stations that individually have small call-out activity in relation to mental health clients. So under our funding bucket of virtual mental health, there have already been models trialled, as the Minister said, in Western New South Wales, in Illawarra, Shoalhaven, local health districts, that they've applied for funding under the virtual mental health component of our package that will provide support for first responders. So PACER-like models that are adapted for regional and rural. So that will enable assessment in the community via technology rather than necessarily having a mental health clinician in person with the police at every location across a wide geography. The context of COVID, which makes this really important, is that it does two things. One, anticipated rise in demand, police call-outs for mental health issues, and secondly, reduces presentations to emergency department. So our concern in the COVID pandemic was trying to reduce wherever possible avoidable presentations to emergency department to free that up for necessary and anticipated increase. So I guess in summary, what we're saying is a PACER model specific to Metro that works well in Metro, utilising the virtual mental health component of our funding. We're going to fund ongoing trials in Illawarra, Shoalhaven, Western New South Wales, and there are other districts like Northern New South Wales where the directors have expressed interest and will be supported. So statewide approach to supporting first responders, but appropriate models for rural, regional and Metro.
We will come back to you, and feel free if you want to
I will.
address anything in the middle of this. So the New South Wales program, the PACER program, has relied in large part upon the experience in Victoria in terms of establishing. Is that right, Mr. Pearce?
No, it was really the trial in Covert.
All right.
There is, published models, both international and interstate, that were referred to.
All right. Well, as you know, Victoria's had a PACER program since at least 2012 or before that, and including in regional Victoria, successful programs in regional Victoria. have you looked at the Victorian model, which all the data says achieves similar positive results to roll out regional mental health services? Have you looked at the Victorian PACER model? Why haven't we implemented the Victorian PACER model?
Well, we have. We've adapted it to our requirements, but as I explained, in regional and rural New South Wales, the approach requires virtual mental health rather than necessarily in-person clinician with the first responder at the scene.
Well,
So, Mr. Shoebridge, may I contribute to this? In terms of rural and regional Victoria, it is often a very different landscape to rural and regional New South Wales, and particularly when you look at Western. Their towns do tend to be closer together than ours do in many parts of rural and regional New South Wales. But look, Victoria's done some terrific programs. I mean, I've been down there myself, and I've worked really closely with the Labor Minister down there, Martin Foley. I think that some of the things that they've done have been really good, and that's what we're looking with some of our suicide prevention strategies as well. So we're happy. I mean, we're not looking at other things. We're working really collaboratively with Victoria. But what we've got to do is what's right for New South Wales, and we've got to take the time, and we've got to ensure now. And that's where COVID, as I said in my opening statement, has actually provided some opportunities for us in the mental health space, because it's allowed us some opportunities to look at things a little bit differently and to be able to expand some programs.
Minister, I accept that. In fact, it's a terrible crisis, but it's forced governments to be more nimble than otherwise would be. And one of the positives of that is the expansion of the PACER program. A program that, will be quite clear, I have supported from the outset.
Oh, it's a great program.
But the concerns, and I think the Honourable Tara Moriarty was raising this in her questions, is if the expansion of the PACER program is funded out of COVID money, what happens when that bucket empties?
Yeah.
Are we going to commit to at least the footprint we've got at the moment on PACER being a permanent footprint?
And that's a really reasonable and valid question, Mr. Shoebridge. But at the moment, I can only answer the questions with the information of which I have, and that is that we have been. I was able to, with the New South Wales Government, secure this injection of funding for COVID. And your question is directly relevant, and it is a very important one. And when we come to budget estimates, you'll be able to grill me about what we're going to do going forward. But we know that this money is available now. We're going to use it. We're going to be really laser focused on how we look at the outcomes of these programs and the results of what we're doing, and then it will be my job, and I take responsibility for that as the Minister for Mental Health. I can't sit here today and guarantee you that forward things with the budget, because I'm going to have to make my case like every other minister to do that.
So how long is it budgeted for, the PACER program? What's the current budget timeframe? Mr. Pearce?
It's for 12 months through to June next year.
All right. And then in terms of funding for a trial, this is the trial in the Central West. Is that the same funding envelope for the trial to be concluded and anything to be implemented over the next 12 months? What's the funding envelope for the Central West trial?
That trial in the Central West was going on and ready to be launched pre-COVID. So that was actually coming from existing funds that we had looked at already. Look, Western New South Wales and the mental health director out there is really innovative, and he was, looking at this stuff.
That's a different bucket of money, and it's not tied to the COVID funding.
That's correct. It was about, Yep.
Minister, how were the 10 PACs, and by PACs I mean police area commands, which is metro police districts, how were the 10 PACs chosen for the expansion of the PACER program in Metro Sydney, and did your office have involvement with that, looking at mental health reports and mental health data? How were they chosen?
Well, I can start to answer, and then I'll hand to Mr. Pearce. But what we did was, when I went out to look at the PACER program pre-COVID, before COVID hit, out at Covert, we actually had other people from other local area commands that came as well, because there's been such huge interest in this from the police in terms of how it was working and the way it was playing out for their officers on the ground. So what we did was we worked with the local area commands and the police local area commands to make sure that they were ones that looked like they wanted to have it, and they were agreeing to give it, a really good go. Because what's really fundamental here with this program is that you got to get the mental health clinicians right, and you've got to get the police.
So were these 10 packs where the police put their hand up and said, we want this?
That's
was
my
that
understanding.
how it was chosen, Mr Pearce?
Two issues. One is data informed, so the police looked at the higher volume call-outs for mental health related issues. And secondly, and critical, is we needed active support and endorsement by the police area commands that they wanted to take it on. So those two components.
Minister, I accept why that might have been chosen as the starting point, but do you accept this proposition, that it's in those police area commands where the leadership hasn't put their hand up and acknowledged the benefits of PACER, that probably there's the greatest amount of work to be done? Because I would have thought anyone in a position of leadership in the police force would look at the results of Covert, and if they're not putting their hand up and asking for some of that, then we have a problem, don't we?
We do, Mr Shoebridge, but to be fair, I mean, I'm not the Minister for Police, and I don't spend a lot of time in police stations and,
I try and avoid it myself.
Yeah,
Not always successfully, but you do what you can.
Me, Mr Shoebridge, but, and I'd like to keep it that way. All I can comment on is what I've seen. And look, that's how I operate. I think it's from years of being a nurse. I have to see things and I have to observe them and I have to feel them to know if they're effective. And obviously then I have all these amazing people that work with me that look at the data and we work out the best approach. What I can categorically tell you is that when I sat in that police station at Covert, the respect that the police officers had for the mental health clinicians would warm your heart. It is incredible.
Minister,
so
with all due respect,
to answer your question as well, is that would I like to see PACER in every single local area command across New South Wales? Yes, I would. Will I work very hard every day to make sure we do that? Yes, I will. But what I have to see, Mr Shoebridge, is I have to see the data and the results. We've had really great results in one spot, and I'm really confident that that can roll out, but I can't categorically tell you that. So that's why we need to do these pilot programs to have a look and see how we go and see how it pans out. But I think, to be fair, if I may say, what I have been directly told by the police officers is how much it's helped them. They were very open with me about the fact that, they'd been trained, they're trained to do things, but that mental health, it's a really complex area with people with very complex needs. And to see them now working together in that space, and not only too, Mr Shoebridge, it's not only when they go out physically to the place that they need to be, it was watching these clinicians work within the confines of the station. That was just incredible. And I'd really love you to go out and have a look and talk to Felicity or Fiona and see the incredible work that they've done.
Minister, I mean, all strength to you in asking for additional budget to deal with PACER, but surely if the PACER program reduces the need for police interventions, reduces the time that police spend attending people in their local area command who have mental health concerns, reduces court costs, surely the funding for that program should come out of the police budget, not out of a separate bucket. Surely, if it's having that a direct effect on reducing, as we would hope to see, the need for police, surely that's where the funding should come from, shouldn't it?
Mr Shoebridge, I may only comment on my own work and my own budget. If you'd like to direct those questions to the Minister for Police, I'd be very grateful, Mr Shoebridge,
Yes.
because I think you make a very strong and powerful point.
Well, he's a notoriously receptive individual, isn't he?
Any collaboration and help would be most thankful.
Yeah. Minister, do we know, I know there's a $73 million bucket of money. How much of that is being spent on the PACER program, so as we can get an idea on how much that's actually costing? And then, if you wouldn't mind, if you have the figure at hand, that's great, but if you wouldn't mind taking it on notice, what would be the cost of expanding the PACER program across all of New South Wales?
So, Mr Shoebridge, the amount allocated to the PACER program from the $73 million COVID money injection is $6.1 million.
Right. And then do you know what it would cost to expand that over the state?
Look, I'd have to take that on notice, Mr. Shoebridge, and it would be really difficult, just to be really honest and upfront, to tell you exactly that, because we're not entirely sure how the models are going to look in different areas as well. We know for the city and for the high volume, as Mr. Pearce said. So we're going to.
Well, then perhaps if you could, if you can't answer it across the whole of the state, how much it would cost to expand it to all the metro commands?
Sure.
That would be a useful figure if you'll take that on notice.
Yeah. No, I will.
Thank you, Minister. You said at the outset that there's been this series of blows to people's mental health and physical health this year. We have drought, we had the fires, now we've had the pandemic and the lockdown. Have you been keeping track of data on some of those awful indicators that we don't really want to talk about, but including on suicides? And have we seen? Have you got some data or response to the data on that you can share with the committee?
In terms of the suicide data, that's something that we're working on getting in a much more timely manner. But all indications at the moment, and I think I'll ask Dr. Wright to comment on this because that's very, very specific. But I will start by saying that all the indications are not showing us an uptake in that, which has been really interesting, Mr. Shoebridge, because when you look at some of the modelling that's recently come out, it was quite almost, and I don't want to be alarmist and say catastrophic, but it was very, very concerning. But I think that one of the really interesting things that's come out of this too has been a decrease in presentations to emergency departments, right, for mental health concerns. Now, in some ways I think, okay, well, that's a positive, but then I know, as Dr. Wright will explain,
Complex
we're
drivers.
concerned, about that we're going to see something, and history would tell us that the really important time is going to be in the following 6 months. But if I may allow Mr. Shoebridge, I'll ask Dr. Wright to elaborate on that because he's the expert.
Okay.
Dr. Wright?
Thank you. We have we track some data very, very regularly and have done for a number of years, and we've been looking closely at some of the activity data during the pandemic period, and we've increased the frequency of some of the reports so that we can see what's happening on a week-to-week basis. And I think that I'll preface my remarks on the particulars of New South Wales by saying that we also stay in contact with our jurisdictional colleagues from elsewhere in Australia and in New Zealand, and the experiences have been very similar across all the states and in New Zealand. And the first one, as the Minister has already mentioned, has been, as has been the case in general health, for mental health there's been a reduction in emergency department attendances. We don't see that as a good thing because I think that you mentioned complex drivers, and I think it's to be very specific. I think that some of the reasons that people are not attending are that they might be concerned that they are going to be at risk of catching an infection, and so they stay away with matters that should receive attention. And the second one is that people will stay away because they feel like the system is so overburdened that they don't want to increase that burden. And so our concern has been that, and it's been an experience in general practice as well across the country. Our concern is that people may be not receiving early attention for mental health issues, and we all know that early attention is much more effective than waiting till things get out of hand. It's one of the reasons that some of the initiatives around virtual healthcare become really useful, because both in the public and the private sector across the country, we've switched to the use of virtual health, telehealth, to conduct a very large proportion of our assessments. Mental health is one of those aspects of health where you can actually conduct almost all of a clinical encounter, including the giving of advice and the issuing of scripts if necessary, using telehealth. We don't necessarily have to have the person physically in the room. there are mixed messages in that reduction in ED attendances. We also saw a reduction in our bed occupancy in the early part of March and April, and we saw, as I've just mentioned, an increase in the use of telehealth and also telephone to conduct assessments in the community. Those changes have actually normalised over the last few weeks. So that, if you like, there was a dip from what we expected year on year, and that's gone back. That's heading back to normal. And again, that's very similar to what's happening in the other states, and we are seeing that as part of a reflection of the fact that hopefully the community is trying very hard to return to normal activity, including the seeking of appropriate help. We have seen a significant increase we're hearing of a significant increase in accessing telephone support lines. It's difficult for us to tell how much of that is people who are reaching out because of the if you like, the general stress and distress that's associated with the restrictions that have been created for all of us through the pandemic, and the fears for what might happen in the future, and those kind of contacts are able to be resolved and receive appropriate support over the telephone, and how much of those are people who would otherwise be accessing our services. But I think that that's why any kind of package to support people's mental health during the pandemic has to match up both at a state level and at a Commonwealth level. The telephone support services, the community-based messaging, which I think is also an important part of a mental health response, and also the access to our specialist level services.
Thanks, Dr. Wright. But one of the parts of my question was, what is the data on suicides? And if the answer is you don't have timely data, and then let me know. Yeah. Do we know what is the situation on that?
Yeah, we don't have current data today on what the suicide rate is. We do have data on ED, emergency department attendances with self-harm, and those attendances have not significantly increased during that period.
And that's where you said there was a dip in those first few months, but it's now returning to what we would...
It is.
A more normalised level.
Yes.
Is that right?
And if I can... And I think that's an important marker, because suicide is the devastating terminal event of a range of mental health problems. And so what we are endeavouring to do is to identify and respond to increasing levels of distress, including levels of self-harm. So monitoring the instances of self-harm and people presenting for self-harm is an early indicator of what could then end up in either an increase or a reduction in the suicide rate.
Minister, are there arrangements being put in place for some real-time data reporting on these kinds of measures? I mean, many other departments have a dashboard where you could get real-time, regular reporting.
Yeah.
We don't see that in the mental health space. So is that part of the projects you're putting on place? Because that would then assist other government services, NGOs and the like, to know what's happening on the ground and respond in a nimble fashion. Are we going to get real-time reporting?
Yeah, and you're exactly right, Mr. Shoebridge, and real-time reporting on suicide data is actually a challenge across Australia, and it's something that, And on presentations.
Yes.
I completely agree with you. You're completely right on that. And it is something, the problem is often that the coronial process takes time in terms of, and you would know that better than me, about determining causation and things. So that's been a challenge. Now, it is something that the federal government are looking at, in terms of our national mental health objectives and things. And it's definitely something that we're looking at. And look, Ms. Shoebridge, I can't give you exact data at the moment, but it doesn't take in a lot of the COVID time, but we should have some really impressive things to release about overall suicide data very soon. We're just making sure that that data is spot on and things. But we have been working, and the branch and people out in the mental health space have been working really, really hard in suicide prevention. Now, that's actually, I am hoping, going to serve us really well in the next 6 months, that we've actually embedded quite a bit of this in. We've got a long way to go, but we have started.
All right. I'll hand back to the opposition. Tara.
So I'll just continue with that theme just for a second before I come back to where I was before. Just in terms of, I'm interested in getting some details generally about the collaboration between New South Wales, Victoria and the Commonwealth. But just to follow on from Mr. Shoebridge's questions, I understand part of that is about the collecting and sharing of data. So I understand the reasons, and this is stuff that we've been through before in terms of whether there's what kind of data there is in this space. I understand that that's an issue. And it's great that something's happening with that, but it seems it's been reported that it's more of an issue, I think, than we realise. And a lot of the federal money, I get that you're the New South Wales Minister, but you're part of this collaboration with the Commonwealth. And money has been announced for funding research into the effects of this, as well as suicide statistics. But it's been reported that we won't get any of that kind of information until 2022. So you're saying 6 months from now. What's the issue with that? Happy to take some details about the federal collaboration if that helps. But 6 months, you're saying the reports from the collaboration is 2022. So.
Yeah, I mean, look, there's two parts to your question, if I may, just so I can think it through, is that you're asking about the collaboration with New South Wales and Victoria and all the other states. So I think that's referring to the National Pandemic Plan. But then your question's also about the suicide data and as you rightly said, the complexities of that and that it's not in real time and things. But I might, Dr. Wright, you've been around this a lot longer than I have in terms of suicide data and things. Would you be able to address that part of the question?
Yes. Look, I think that the one of the issues that's been up for discussion for a number of years has been the potential value of a suicide register, and I think that's both at a national and at a state level, and there's a real interest in trying to develop that capability up. And there are suicide register models already in existence in both Victoria and in Queensland. They're quite different models, and so but I think that as part of the suicide reduction initiatives in New South Wales, there's a serious consideration about what we might be able to do to actually improve not just the timeliness of the data, but the completeness of the data, because it's often data from different sources. And so, just as an example, and we've there's actually very useful data that can be made available from police, because they go to thousands of incidents per year, which are mental health incidents, and one of the great things, and there are some good benefits out of our entire focus being shifted to the pandemic, has been a willingness at a state level to actually share some of that data so that we can put together comprehensive sets. It doesn't solve the entire problem, but it's a piece of the jigsaw. And so the part of the ministry which helps with our mental health data, their director showed us yesterday some of his modelling, which includes inputs from the police data on presentations. It just makes us a little more confident about the sorts of conclusions that we're drawing when we have all the available data there. And barriers to sharing that data, which have existed for many years, have actually been able to be overcome. quite quickly during the course of the pandemic, and we're all quite determined to make sure that the benefits that we've had in that space have actually been that we can maintain those going forward, because these are important things, not just during the course of a pandemic. They're important. They're important for our mental health services for the future as well.
And look, there is currently, as part of our suicide initiatives, but this isn't COVID related, but I'm happy, well, it is COVID, but the initiative was before COVID. It's not out of this COVID funding, of which the inquiry is about. But I'm happy to share that we are collaborating with Communities and Justice to look at a New South Wales suicide register. It's in its very early days at the moment, and I'm happy to update you as that progresses and what happens, because as Dr. It's really important. Your question's a really good one, as was Mr. Shoebridge's. We are working on it. Have we got a way to go? Yes, we have, and that's because of those challenges within that.
So the collaboration between the states and
Yep.
I acknowledge both of your answers in terms of working and sharing data as part of the National Pandemic Plan. I think that's what it's called.
Yeah.
I understand that all of this is somewhat of a work in progress, but based on what you've just said, the Commonwealth Senate inquiry into the response to COVID has said that all states have agreed to share this data, but New South Wales has not. So has that changed? Like general discussions you've just talked about, but an actual sharing of data going forward, so we have a real picture of what's happening across the country. Is that something that New South Wales is going to participate in?
Look, I am certainly not aware, and Dr. Wright just looked at me too, that we've said that we won't share the data. So we'll have to take that on notice if that's just to verify that, like respectfully, I say that. I think that, in terms of and as Dr. Wright pointed out, another opportunity that COVID has provided is that ability to share data across agencies, and through the Data Analytics Centre that, Mr. Dominello's championed for years. And I think too, look, I've always been on that bandwagon. My first inquiry when I came in here was on service coordination. It's something I feel really strongly about. So I think the more that we can share that information, share the data, the better our outcomes are. And I'm sure you would agree. And in terms of the National Pandemic Plan, that was just brought about by Victoria and New South Wales. And that was brought about because I'd heard about some really fabulous things that Victoria was doing. I picked up the phone, I spoke to your counterpart in Victoria, who's just a terrific bloke and really cares about mental health. And we decided that we'd put politics aside, and I went down there and I looked at some of the great programs that they're running, particularly at their St Vincent Centre with their Safe Haven Cafe, which we are copying. And I'm sure you wouldn't mind if I called him Martin. Martin and I are in regular contact via phone, via text message, looking at that. We brought, and he's been in the mental health space a lot longer than myself as a minister, and we were able to bring all the ministers across Australia to the table, which has never been done before. In some states, your Minister for Health is also your Minister for Mental Health, but like for Victoria and us and other places, it's different. In the ACT Minister for Mental Health is actually a member of the Greens, Mr. Shoebridge.
I know, very good.
He is a very nice person, and so we all really work together, and it's actually been one of the really great things to come out of this as well. And although I had done that previously with Martin, we're really keen to work together. We're actually having another meeting again, hopefully next week. Trying to organise diaries is another challenge. But I think it's really important, because I think if we can share all of that, and not just the data, but the information and about what works, we're going to get better outcomes. And I mean, I think if we're all to be really honest with each other, and it's something often that the upper house is so much better at than the lower house, is that when we work together on getting really good policy solutions, we do get some pretty good outcomes. But the plan and what we're doing about it is that it's one of the things that it actually stresses is to use people with lived experience and carers, and in terms of designing and delivering responses. Well, that's what we do with everything that we're doing, and particularly in this COVID package. We've actually also a part of the COVID announcements as well was a warm line, which is, and I know you're familiar with Bean, and that they're running and trialling, and we're really excited about that, because that's about looking after carers in the mental health, looking after people who need help in the mental health space, but actually using people with lived experience to actually answer the phone. I'm really excited about this program. So we're going to wait and see. And I'd encourage you to keep an eye on that one as well. I think it's going to be a really positive one, and it directly relates to the National Pandemic Plan. Another thing that the National Pandemic Plan also says is about community-based approaches, and we've demonstrated that with our commitment with 180 new community-based positions, 216 if you want to include the PACER clinicians as well. And it also talks about implementing new models of care, and I think that's exactly what we've had the ability. We've probably been able to fast track a little bit with COVID, and that's actually, some people say, oh, you shouldn't say that, but I'm just really proud of the fact that we have been able to roll out all of these programs, and that, that is one opportunity that it's provided because we've had to be faster in our outlook and our delivery. So that I think is really positive. It also talks about flexible solutions, and that's what we're trying to do as well, and that's why we're looking at models. And I will never, as long as I'm privileged enough to sit in this chair as the Minister for Mental Health, I will never impose a one-size-fits-all on things for models of care, because I know as a ex-clinician that it simply doesn't work. So I think that flexible model of care is one of the most important things that we can do. We can't say that if this is going to work in Covert, it's going to work in Cowra, or if this is going to work in Bondi, it's going to work in Broken Hill. We know it doesn't. So I think those flexible models of care are really important. I'm happy with the National Pandemic Plan. I think it's going to have a way to go, but look, it's a good start, and it's great to see mental health at the table in National Cabinet and people talking about mental health and us all collaborating. And look, long may it last, because I think it's the only way forward.
So what's the timeline for it?
Well, it's out.
The plan, the collaboration, the formal arrangements.
Well, because it's only just started, so we only had that one meeting, and then New South Wales and Victoria. Well, to be fair, it was my team and Martin's team that just burned the candle to try and get this going, along with, I consider David and Murray part of my team. And we did that, and we had agreements from the states as well. As I said, we're planning to meet again next week. And look, Minister Hunt has, I think he's come out and shared a very personal story of his own, which probably influences the gravitas that he places on mental health. And I think that's a really good thing. In terms of how long is it going to last, what's it going to do, I don't know. It's really early days, but I'll tell you what, I'm going to do everything I can in my position to make sure that it does, and I know Martin feels the same.
But has there been discussion about how long it's going to last and what it's going to do?
Well, how long's the pandemic going to last? So, it's the pandemic.
What resources are allocated from New South Wales to this plan?
Well, our resources are time. We haven't added any extra resources to this plan, but the plan directly reflects the $73 million that's been injected.
Yeah, so New South Wales has signed up to a national pandemic plan with Victoria and the Commonwealth, but we're not putting additional money in, or out of the 73 million, how much of it is going towards the national plan? So
New South Wales has invested more in the COVID-19 pandemic response in terms of frontline services than any other state. So $79 million. In terms of, and maybe I misinterpreted your question, I thought you were thinking more of admin and things like that with the pandemic plan. No, we haven't set aside, we've been helped by COAG, which I don't think is going to exist anymore in terms of setting up all the teleconference and everything. But our investment in mental health directly reflects the National Pandemic Plan.
Sure,
so we've put in $73 million. It's principle-based, the plan. It's not talking about certain services that you need to implement. And that's why I just talked to you then about the principles of lived experience, community-based approach, new models of care and flexible solutions, which is exactly what our investment reflects.
And look, that's welcome. And I've said before, any kind of collaboration around the pandemic is welcome. Of course, states should be sharing ideas and working with the Commonwealth, but I don't really know what it is based on this answer. So if it's really New South Wales, Victoria and the Commonwealth getting together to share what's happening in both of those states and the Commonwealth, or what's the point of it?
What's the point
Yes.
of the National Pandemic Plan? The point of the National Pandemic, have you seen the National Pandemic Plan?
Yes.
Yeah? So it's a plan that actually allows everyone a way forward, looking at really key principles that we know are going to have the best results for people. I mean, when you say what's the point, I mean, you said previously, and I know you've acknowledged this before, that all of the states and territories working together in one space is a really powerful thing.
Sure,
You know,
I'm
it's
not
the
critical
first
of that.
time.
I think it's great that the states and the Commonwealth, or two states and the Commonwealth, are working
Well,
together.
it's not two states, it's all states.
Sure, have done
It's all
some great work.
states and
but
territories.
Maybe a better way to phrase it is, what's the point for New South Wales? What is New South Wales getting out of being part of, or what is New South Wales contributing?
The point is that when you want to make real and meaningful change, is that you work together and you have a seat at the table.
But Minister,
That's actually the point.
What I'm
And-
asking on behalf of the people of New South Wales is, what does real and meaningful change mean?
Well, what real and meaningful change means, as I've said to you before, and I'm not sure how I can better explain this, maybe I'll have to ask Dr. Wright, but we looked at the guiding principles, and those guiding principles of lived experience, you know, with your time representing in mental health, how important that is. So what have we done? I just talked about a warm line that's been created through Bean about people with lived experience. We talk about a community-based approach and how important that is. What have we done? We've put in 180 new clinicians into community-based services. You ask about what's the point of new models of care. Well, new models of care are important, and that collaboration between states means you can share information. It means I went down to Victoria and I could see how well that system was working and that we're going to do that here. But I mean, I think to say what's the point of a national pandemic plan is quite an incredible statement, but I'll ask Dr. Wright to
Can I just clarify? It's not a statement. I've said I'm supportive of states working together.
point of
I've said
order.
it
Question
repeatedly.
was,
Point of
what's
order.
the point?
Point of order.
No, I can tell where this point of order is going to
I've
go.
sat back
I
very
can-
quietly.
Pandemic plan.
I've sat back very quietly, but I think it's behoves us all to revert back to question and answer and without commentary.
You know, to the point of order, the minister was again taking issue with the question rather than just simply answering it. She had already given some answer, and there was just a barb at the end, which frankly was unbecoming a minister.
We're
of
to the
Crown.
point of order, both parties.
No, but I think I have my head
No one comes
around-
to this court with clean hands, with respect.
Well, I haven't said anything.
I think to
So-
both of you, I think I
My
have the
point-
gist of the point of
was,
order
can we revert?
and the response to the point of order, and I think there's
Wise
merit on
questions.
both arguments. Minister, best if you don't take issue with the question and just try and address the question as best you can. You're allowed to, critique where it comes from, but please, if you take issue with the question, you're going to invite the Honourable Tara Moriarty to take issue with you taking issue, and that's what happened. So to the Honourable Tara Moriarty, I'd invite you not to bite. And then I think Dr. Wright was going to provide us with some actual information. So Dr. Wright.
So I think the question is, what's the point of the National Pandemic Mental Health Plan? And I think that it is a fair question. I think that there are some things during the pandemic which have changed dramatically, and we've been unable to do things that we've previously done. But there are a number of things which we've been doing and reforms that we've been enacting over a period of time that the pandemic response encourages us to actually speed them up. And so what the pandemic plan does is it shows us where the emphasis ought to be in terms of our services. Now, the pandemic is it goes without saying, is a whole of community problem, and the best approach is a population health approach. And so the mental health services are looking at how do we do that from a population health perspective, and that requires that the state-run services and the traditionally Commonwealth-funded services, and also the other parts of government and community which have a stake in mental health and well-being, all work to the same plan. And so the only way to do that, because of the way our services are tiered, is to have an agreement between the Commonwealth and the states, and that's what that plan is. We will not be able to manage what we anticipate will be some increase in demand for our services over the next months and years if we don't have very, very clear understanding and cooperation between the services that we are collectively responsible for and the private sector and the primary health sector, which is funded by the Commonwealth. So it's absolutely essential that we are literally all got the same script, and that's what that plan is, and that allows, and the plan also doesn't exist in glorious isolation. It builds on the 5th National Mental Health and Suicide Prevention Plan, and it's actually stated within the National Pandemic Response Plan that some of the key aspects of the 5th National Mental Health Plan are absolutely perfect to respond to the demands of the pandemic, particularly those aspects which are about localised, integrated planning of services built around PHNs, local health districts, and other providers in those local areas. And so it builds on what is already there. It is absolutely consistent with the things which have been happening, both from a reform perspective within New South Wales, but also in the specific responses to the pandemic. But it also shows us where we need to go, and you'll be pleased that the issue of better and more comprehensive data is actually one of the 3 big ticket items in that plan. So I do think it's it's a very important and necessary development. It also gives us the opportunity through the COAG-linked structures at a mental health level to share success and problem solve with our interstate colleagues as we make our way through what is still essentially uncharted territory.
Thanks, Dr. Wright. Minister, what, if any, input did your office have when the first set of public health restrictions were being put in place, and there was a great deal of uncertainty in the community about what that meant in terms of visiting friends, visiting partners, showing sort of support for people who might need it in the community? What, if any, role did you have when that initial set of public health orders were being not only crafted, but then communicated?
So, as you know, Mr. Bridgen, I think the Minister for Health has already been a witness to this committee, but those public health orders are signed by him as the Minister for Health. In terms of, you asked me what my office and what myself had in terms of conversations and input into that. Look, I've spoken to the Minister for Health very regularly over this period of time. He has a real commitment to mental health and to the well-being of people. So I have constantly raised things with him, and that's how the new mechanism of government works, is that he is the cluster lead in the cluster of health and I sit in that cluster. So it's my responsibility to have that communication with him, to tell him that. I've had numerous conversations. I also was dialing in daily to the teleconference that New South Wales Health had as well. So I was hearing all of those aspects, and it allowed me, as the Minister for Mental Health, to have, I hate using this lens, but I don't know how to say, I had that mental health lens over that whole health response. And there's no doubt, and I say this very honestly, that there is no doubt that there has not, by the entire Cabinet, and particularly by the Minister for Health, had a real focus on the need for mental health. He was very, very supportive and instrumental in this package that we were putting forward.
Mm-hmm. But Minister, my question is really directed to what was around about 2 months of real uncertainty out in the community about the circumstances in which someone could go and visit a friend who might be having significant mental distress, go and visit a partner who was living in a different house, go and visit an elderly relative who was feeling isolated. There was a lot of uncertainty in the community about in what circumstances they could provide that peer-to-peer support. And there weren't the guidelines in place directing us. Well, how did that sort of slip through the cracks? Why was there so much uncertainty when we know people need that kind of support?
Mr. Shubridge, I hate to disagree with you because I've seen what happens, but I think that the public health orders had real direction to them and certainty about what you could and you couldn't do. Because I think if they hadn't, we wouldn't have had the phenomenal results that we've had in terms of people looking at those public health orders, looking at what they could and could do. I mean, those things, and that was a national approach. They were done on a national level at National Cabinet and discussed at those levels.
Minister, for example, visiting a close friend who is having a mental health, who needed significant support for mental health. We had the Commissioner for Police suggesting that that may come under one exception. We had the Attorney General suggesting it might come under a different exception. Nobody could point to any clear part of the public health orders that allowed for that kind of visit to happen. There really was a large amount of uncertainty in that space. I'm not suggesting every response from a government will be perfect. It's complex, like it was very complex. But looking back, do you think maybe there was a need for a greater set of guidelines around those sorts of things to give people that kind of direction?
So Shubhaj,
And it's easy in hindsight. I
Yeah,
accept
yeah,
that.
and
It's
I
complex
understand that,
hard.
and I understand your question, and it's a good question, but I think it really needs to be directed at the Minister for Health or as you mentioned, the Attorney General or the Minister for Police. I certainly wasn't, making comment on those, and I haven't, and that's really a question for them. In terms of looking back in hindsight, and the second part of your question. I think that, hindsight's always a great thing, isn't it, really? But I think what you have to look at is that the number one priority for the New South Wales Government and for putting in those health orders, which were really difficult for people to adhere to. I know how I felt about not being able to see Mum, and everyone in this room would feel the same way. And I know, I have a husband with a terrible dodgy chest, and I didn't want him to get that, and that meant that the girls couldn't, we had to be really careful managing that. So I do understand, but the government's absolute number one priority was to keep people safe. And I think that although some of those things in hindsight might have been hard, if you use the word uncertain, I think we absolutely did the best that we could at the time, and I think that's reflected in the results.
Minister, I'm as I said to you, nobody is suggesting you get everything absolutely right. Decisions were being made as data was coming in. It was really, a novel crisis that people responded to, and this isn't a criticism to suggest that everything had to be right. But you talk about keeping people safe, and part of keeping people safe is making sure people's mental health concerns are addressed. Every bit as important as keeping them physically safe. And I'm just asking you whether, if first, will there be a review of the extent to which those mental health concerns were picked up and actively communicated and addressed? Is there that kind of review going on?
Well, Mr. Shubhaj, I couldn't answer if there was a review because I think we're still in it. We're still looking at it. I think that too, providing care for people was always an exception, and people could receive care, and if they needed to, if you were really concerned about someone. And our government and non-government sector did an incredible job during that period in terms of looking out for people with mental health issues and making sure that people were looked after and doing that. I wasn't.
But Minister, I'm asking about.
I wasn't involved in the health decisions, if that's what you're asking me, Mr. Shubhaj.
Yeah, well, I suppose I'm asking you.
My contribution was to speak regularly with the Minister for Health and put that lens across, and my representations always with all of the people in positions that were making those was to make sure that those things were considered.
Do you think there would be benefit in if we have a second wave, or if there is a further lockdown, or would there be a benefit in addition to the quite dry and hard to interpret health orders, there being a set of clear Q&As and guidelines, and one of those guidelines being the circumstances in which you can provide peer-to-peer mental health support in a lockdown? Because that I think was one of the missing parts. Nobody knew, there was no clarity in the circumstances in which people could provide that kind of peer-to-peer mental support during the lockdown.
I mean, my understanding and my information is that people were able, people had to access support in different ways. That's what we had to do. We all had to look at different ways. In terms of your question about a review, I think it's always really beneficial to look at things and look at how they've been done. And, I'll certainly be saying, and we'll certainly be looking at that from a mental health perspective.
Just to be clear, we put up early on a series of explainers about how it was working, And if there was one area where we got hundreds and hundreds of questions, it was about this issue. And I can tell you, my experience in communicating with the public was they didn't know what they could and couldn't do, and it was an area of unnecessary uncertainty.
Okay. Well, look, I can only take you on your, what you're saying to me, and I think to be fair, there was, that level, because we'd never done this before.
And Minister, this isn't saying that necessarily means it was bad decision making. I'm just saying that was a gap, and I'm asking if you could review it and maybe consider addressing it, because it was complex and hard.
Certainly from a mental health perspective, I'm going to be looking at everything, because I think there's a lot to learn from this.
Minister, we saw thousands of fines issued during the lockdown, and I'm not going to have this isn't time to have a discussion about the role of policing in a lockdown. I know this is a mental health inquiry. But have you had any conversations with the Minister for Police or the Commissioner of Police about how those fines are reviewed, and considering whether or not people's mental health may have been a driver in their behaviour which led to them breaching the guidelines? And I say this because even a cursory review of some of the conduct clearly showed there were quite distressed and disturbed people who received quite significant fines.
And Mr Shoebridge, and I say this with the greatest of respect, you would know that doesn't fit in. I'm the Minister for Mental Health, I'm not the Minister for Police, and I'm not the Attorney General. And as you so rightly said, this is a inquiry into the COVID-19 pandemic. My understanding too was that there were fees that were waived as well from the Commissioner. Your question to me was, have I spoken to them? No, I haven't spoken to them personally about these things.
Do you think there would be merit in opening a dialogue with the Commissioner of Police to ensure that if there are reviews being undertaken of fines related to the COVID-19, that we are not criminalising somebody's mental illness as opposed to policing the pandemic? We're not policing someone's mental illness.
Mr Shoebridge, it would be my absolute expectation that would be the case. And if you presented me with a case where you felt that was not adhered to, I would 100% look into that and make representations.
Well,
but
Minister,
I haven't.
I will send you the correspondence first thing next week.
Sure.
With the cases
Doors
that I think
always open,
clearly,
Mr Shoebridge.
clearly I think demonstrate, that the conduct arose out of mental illness.
Yep.
Just on a cursory review of the facts.
As I said, I can't. You can tell me this in an inquiry, but you need to provide me with the information. You need to provide me with the charts.
I understand that. My question was whether or not you'd had those meetings with the Commissioner to try and do that. The answer, I've got that answer, and I thank you, and there's a way forward. So thank you.
I mean, I've always been like that here. My door is always open, and I would rather know than not know.
Minister, were you consulted about the mental health impacts of reopening poker machines in New South Wales, given we know what a disastrous mental health impact poker machines has on many people's mental health?
No, Mr Shoebridge, I was not.
Do you think before a decision like that is made that you should have been consulted as the Minister for Mental Health, knowing that so much of the harm that's caused by poker machines arises out of people's mental illness and addictive personality traits?
Mr Shoebridge, I think for me, in terms of mental health, one of the most important things that we can do is we need to, in a timely and a safe manner, lift the restrictions that we have. We have people out there with no jobs. We have people out there whose income has been cut in half or been cut completely. That really concerns me about their mental health. And as much as I can do as the Minister for Mental Health in New South Wales, if we have a situation where we have people that are going to be out of work for long periods of time, where they can't, people that work in clubs in rural and regional New South Wales, people whose entire livelihoods depend on those jobs that they have, then I'm going to be looking at quite an extensive and high rise curve. So my focus is that we know that economic situations and economic stimulus are one of the biggest drivers of mental health issues. So one of the things that I really want to see happening is that we start to get back to life as is safely possible to be able to do that.
But Minister,
and that is my objective.
I accept the financial costs that we've seen, people facing, some catastrophic collapse in their income. How is that in any way helped by opening up poker machines where people can put their more limited income straight down a poker machine at a time when surely they need financial support and to be protected from that? How does that how is anyone helped other than the clubs who reap the profits? How is anyone helped by opening poker machines?
This is an inquiry about mental health and COVID-19, not about poker machines. I'm very well aware of your strong stance on gambling and poker machines, but that is not something that comes under my remit as the Minister for Mental Health in New South Wales.
Well, Minister, could I suggest that it does come under what most people would expect it to come under, the responsibility of a Minister for Mental Health, because we know a substantial amount of the damage done through poker machines
Point of order,
comes
Chair.
about through
Point of
mental
order.
illness and...
Point of order, Chair.
Let me just finish the question, then I'll take your point of order. Comes about through mental illness and addictive personality traits. And why aren't you working in that space?
I accept it's a very important topic, and I think that the Minister has genuinely attempted to answer the two previous questions which were in a similar vein and said it's not something, it's also conjecture about what may happen in the future. I'm not sure she's able to answer it. I'm sure she will very capably answer in the best way possible, but I've seen the other questions go through. I ask that the question be drawn back to the inquiry and the Minister's portfolio responsibilities.
You want to deal with it? You want me to do it?
I wouldn't mind another view on it, if there is another view on it.
Look, as we are so often reminded in these sorts of hearings, how the Minister answers is a matter for her. The question seems entirely in order to me.
That doesn't address the point of order, with respect.
Well, it does. You've taken a point of order
With
on the
respect, it doesn't
question.
at all.
There is no
Look,
point of order.
I
You're not
have
the
heard
chair.
the point of order. I have heard the point of order, and I've got to be frank. When the point of order's on my questions, I do appreciate somebody else than myself having a view about it. It is a bit surreal. I do think...
Tribes of as yet undiscovered Peruvian Indians knew that he was going to oppose my point of order, so I'm not sure it's important.
So I believe the question relates to the terms of reference, and I believe the Minister can answer the question as she sees fit, and she's shown herself capable of doing that. And so I do think it relates to the terms of reference, and so I think it was in order, but I appreciate the point of order, Minister.
Sorry, it's quite Mr. Shubridge, I've answered your question in the best way that I'm able to as the Minister for Mental Health in New South Wales.
All right, my last question on this, Minister, is simply this. We saw thousands and thousands of people and families who've finally got relief from the damage being done by poker machines, who had months where paychecks weren't just being eaten up at the local poker machines. And surely this was a chance, wasn't it, to break that addictive link? Why weren't resources put in place, even if you were opening up poker machines, to give people mental health support so as they could break that addictive link?
Mr. Shubridge, I understand the point that you're making, and it is a very valid one. I am the Minister for Mental Health in New South Wales. If individuals are having issues with gambling and things, there are support services in place that can help them. Not everyone that chooses to do that has a mental illness. And it's the same thing if you asked me about whether I consulted on, going back into pubs. And, I think that's a question that you can ask to, I think it would be the Minister that has oversight over clubs and gaming. But I understand the point you're making. I appreciate that it's a very valid one. I appreciate that it's a problem. I know myself how I feel when I have seen people that I know are very vulnerable and that, that money going through the poker machine. I understand what you're saying, but it is not in my remit as the Minister for Mental Health in New South Wales. But I thank you for your question.
Minister, the last question I have for you today is simply if you could provide us with an itemised list of the money that's been spent, how the $73 million package has been spent. Do you have an itemised list of, first of all, where it will be spent, and secondly, how much has been spent to date?
I would probably have to I can give you an absolute itemised account of where I've got the table in front of me of what we're spending on each thing that we've announced. In terms of what the money that's been spent to date, I think it would be fair if we took that on notice, Mr. Shoebridge.
Well,
and
can we
got
do that
back
in
to
those
you.
two parts then, Minister? Can you run through?
Yeah, sure. I'll give you the first one that gives you an exact breakdown of where we've spent the money and allocated it. Absolutely. Right now, can I keep it here just with me at the moment?
You can just read it on if you want.
Oh, sorry. Yeah, sure. Okay. Sorry, Mr. Shoebridge. I apologise. So enhancing the capacity of the mental health 1800 line will be putting in $16.4 million. The virtual mental health expansion to all local health districts across New South Wales will be $20 million. Supporting first responders, which we spent a great deal talking about this morning, will be $6.1 million. Enhancing diversional therapy activities in acute inpatient units right across New South Wales. So that's every unit that will receive that partial of that funding. The total package is $6,050,000. Enhancing the capacity of community mental health services, and that's including support for at-risk groups such as older persons, youth and people with a disability, will be $21 million. We're implementing the Tresillian Sleep Well Baby program for 6 months during the pandemic. That will be $1,440,000. We're looking at, we've contributed $1 million to an organisation to establish residential supported living with the Habilis model, something that we've also borrowed from our friends in Victoria. We'll be looking at a warm line for which we talked about, a warm line for people with a mental illness run by people with lived experience of $800,000. And then there's one thing that I haven't, we're also looking at $500,000 into psychiatric assistance dogs.
Thank you, Minister. And the spend to date you'll provide on notice.
Yes, the spend up to date, sorry?
I can comment if you like.
Oh, yes, Mr. Pearce said he'd like to comment. Mr. Shoebridge, are you conducive to that?
Yes, if that's okay,
In my
Tara.
time, but
Is
yes,
that
I
all right?
am.
Yeah,
Well, only if
Mr.
you're
Pearce.
happy.
I'm happy.
Yeah, Ms. Pearce.
Just quick early advice that the allocations of the funding have been advised to all the local health districts, and the focus will be on July through to June next year for that expenditure. So there's been minimal expenditure against those programs. In fact, the package has only been announced a little over a month ago, and there's some, recruitment for some of those strategies. So
we would look to have expenditure really from commencing in 1 July,
yeah,
realistically.
effectively, yeah.
Right.
And also, Mr. Shoebridge, I'm very happy to, if you think that it would be helpful to keep you updated, on the progress of that. And I also did forget, Mr. Shoebridge, I'm sorry, and I'm sorry, Ms. Moriarty, that we also gave $6 million to Lifeline. So that was in addition to the 73, and that actually brought the package up to 79, but we announced that before.
Yeah. And thank you, Minister. I think both my office and the Office of Kate Fairman would appreciate that update.
We do actually update the Office of Kate Fairman, but I'm very happy to include you, Mr. Shoebridge.
Thanks.
What about me?
I always include you.
Well, it's your
very
call now,
good.
Tara,
Indeed.
so it's over to you. Yeah.
So just to clarify, and Mr. Pearce, probably from your answer, so this is money that's allocated for the next financial year? And
Correct.
Sorry.
Yeah, the vast majority. Some of the one-off announcements that the Minister made, like to Tresillian, etc., is a grant to those organisations. But out to our local health districts who are going to enact most of the key strategies, that's funding from 1st of July.
Right. So
And Lifeline's gone out too, as well.
yes.
Yep.
Yeah. So that's separate to the 70th. Yep. And so can I also just clarify that therefore none of the programs, so I'm grateful for the list that you've just read out of the programs, the breakdown of the money, but essentially none of these are committed to or guaranteed past this next 12 months?
It's specific COVID money that's gone out for that. That's correct.
Right.
Yep.
So, sorry, I'll just turn that off. Part of that, so earlier, and I think just in this just list that you've read out, we've talked about, and sorry if I've got the figures wrong, but is it 180 positions?
That's correct. So 180 community-based positions, but if you add in the 36 PACER, that brings you to 216.
So, okay, so the police positions are separate. Where are the 180 positions, what are they and where are they going to be based?
Yep. So Mr. Pearce can elaborate on that. We're working through that at the moment. What I wanted to make sure that we did, and Mr. Pearce shares my passion for this, is that as I mentioned before, I don't I'm not the sort of person that says, right, this is what we want you to do and this is what we're going to give you for and this is what you have to do with it, because every area in New South Wales is different. So take, for example, to be able to explain that further, take, for example, St Vincent's in Sydney's eastern suburbs. So one of the things that they were really concerned about during this time of COVID was that they have a high proportion of people that suffer from a mental health illness that are homeless. So they really want to target their extra FTE, their extra capacity to build on helping those people and dealing with those mental health issues that solely relate to that. Now, in northern New South Wales, it may be completely different. And in some of the communities that I live close to, it might be the fact that they've actually just been through bushfires and now they're struck with COVID. And so they want to tailor those positions for that. So that's my directive to Mr Pearce, and he has been very, very supportive of that. And that is something that we're doing. But Mr Pearce, would you like to elaborate further on that for?
Yeah, happy to give you approximate figures against the key strategies. So enhancing the capacity of the mental health line, that was the 16.4 million, approximately 30 new staff there. The virtual mental health expansion, a significant proportion of that will be expended on technology, but approximately 50 new staff. And then there's a specific 100 additional staff across all LHDs to support vulnerable groups. So we've invited each of the LHDs to provide submissions back to us. We've indicated what funding each of them will receive, and we've asked them to identify from their local intel the vulnerable groups in their community. So just by way of example, you could imagine in Far West New South Wales, the Aboriginal population is a particularly vulnerable group that would need focused support. For inner city, we've invited them to consider homeless people, rough sleepers, as a key group that they'd want to focus on, by way of example. So they'll come back to us in the next couple of weeks with their recommendations around how they're going to attribute their proportion of that 100 FTE in their district.
Okay, so the timeline for those districts I don't mean area, I won't say areas, but not geographically, but the areas of interest, is the next couple of weeks.
Yep.
So have any of the positions been filled yet?
No.
So they should
So
all
this
be...
is funding from 1st of July.
Right.
Yep. And they've all been given advance notice on their the positions they're getting and the funding they're getting. And we've asked them to do that piece of work and get back to us as soon as possible.
So just to clarify that, so they've been told what positions they'll be getting and the funding, but they decide
The quantum
what to do
of,
locally?
Correct. The
Right.
quantum of positions and the funding they're getting.
Yeah.
And then they'll identify the vulnerable communities that they're going to support within that funding envelope.
And that's expected, so it would be fair to expect those positions to be filled in July?
To be advertised as soon as possible. So the only rider put on that, of course, is with all recruitment process, that takes some time. And so yes, they're funded from July.
But only for 1 year?
Correct.
Right. And so what kind of, so will they be permanent positions only for 1 year? What type of positions will they be?
There'll be positions funded for 1 year.
Right. I mean, these are pretty serious issues across each of these areas.
Look, they certainly are, and it's the same with the bushfire response as well, and the fact that we had to fund extra positions to ensure that we increased our ability for our capacity to be increased, and that's exactly what we've done in the potentiation of COVID. What I'm expecting, and I don't know because I haven't seen it yet, and we're only just starting this, but what I'm expecting is that these positions will end up being, you know, very essential to the overall services of mental health being provided. But the great thing is now we can have these positions, we can put them on the ground, we will assess them, we will look at them. Mr Pearce and I will keep a laser sharp eye on those appointments and those processes to ensure that they're done in a very timely manner. And then we'll look at them. And if we find that we need to keep those positions to meet that need, then that's certainly something that I'll be advocating for, and that I'm sure that you will have great interest in asking me questions about during the budget estimates hearing, I would imagine.
Indeed.
When are we going to get a budget?
Mr. Shoebridge, that's something you'll have to
A highly predictable
This
answer.
is not
all right.
Gee, you were quick out of the bolt there, though.
Yeah, wake me
I thought
up.
you might tell us when we're going to get a budget.
I'd
That's
suggest
all.
we were doing
I'm
budget
so
estimates
flattered
in
that you
December.
think that I'm up there, that I'd know the exact date of when the budget's, but thanks.
It's worth a go.
Yeah.
All right. Sorry, Tara.
No, you're fine. Very good question. Can you give us some idea of what types of positions these will be? So are we talking nurses? Are we talking doctors? Are we talking admin? What's the breakdown?
Yeah, and look, really good question, but something that, again, I feel very adamant that it's the local health districts that need to come back to us to tell them what their needs are and where they think that's going to help. Whether that's going to mean we're not going to be prescriptive, we've just said expert mental health clinicians. We just want, and look, it's really interesting because, you know, when you look at Felicity and Fiona at Cogra, you know, one's a mental health nurse, and interestingly enough, an English-trained mental health nurse, so that's her complete specialty is mental health nursing, and then Felicity, who's an OT. Now, I wouldn't have, you know, 5 years ago, if you'd asked me what involvement OTs had in mental health, to be hand on heart, I wouldn't have thought that was, you know, because I didn't know as much about it as I do now. But, you know, she does an incredible job as an OT and it's a real expertise. So I think it's important for us to hear, and that's what Mr. Pearce has been doing. He's been going out to the LHDs. He's run an LHD himself, so he understands that. And then we're going to ask them what they need. Because that's, and I think you would, I may be so presumptuous in saying that you would be supportive of the fact that we don't want to tell them what they have to do, because I don't know what the needs in Lismore are. You know, I can't, and I don't think that, you know, the mental health branch in Sydney should be telling people what their needs are in wherever these positions are good. They need to tell us where they need to base these positions, how they're going to target the most vulnerable people, and how they're going to get the best outcomes.
Yeah, I think that's perfectly reasonable. I think it's very useful to these local areas to ask for their input on what they think they need, but they are going to be constrained by the budget that you've allocated. So they've been told already what budget they will have for how many staff. They just get to determine within it what positions they can fill. So presumably if every single area wanted a psychiatrist or a psychologist, the budget would be blown pretty quickly. So there must be some idea of what's going to be allowed.
Look, if every area could get access to a psychiatrist, I reckon we'd find them, but there's a national shortage. But yeah, look, it's going to depend on where they think. And to be fair too, your point is correct, but some people also might think that they want to have 4 peer support workers with lived experience. So that's going to be up to them and for them to come back, and we'll allow that to happen, and we'll look at all of those needs with our funding. Did you want to elaborate any more, Mr. Pearce, on that?
Yeah, just from experience, so we've allocated quite generous funding for the FTE, and you would have noted I said approximate FTE, because in a sense that's potentially a minimum rather than definitive. As the Minister just mentioned, a really important component of the workforce is the peer support workforce, as well as clinical positions. So it averages out. We'll get some advice back from each of the districts. There'll be some nurses in there, there'll be some allied health, there'll potentially be some peer support workers, there might be some psychiatry support, but we of course provide them the funding envelope so that they can work from that in order to do accurate costing of what their staff profile would look like with that amount of money.
Sure.
And may I add one more thing? Sorry, Addie. Mr. Pearce actually said to me as well that the feedback from the local mental health directors about this funding has just been overwhelmingly positive. Like, they're really on board. And look, you can test all that and ring them. I'm not just saying that. This is what Mr. Pearce directly told me. So we're actually really, you know, that's a good thing.
Okay, so can I just come back to, I think we touched on this before, and I just want to clarify. So I think Mr. Shoebridge was asking questions, or perhaps Doctor, you were talking about whether there has been an increase in presentations to emergency departments. So just to clarify, sorry, I think you said that there wasn't.
No, there was. So during the second part of March and April, there was a reduction in mental health presentations based on a comparison year on year. That reduction has returned to normal over the last few weeks.
Okay. Has there been an increase in mental health patients going into inpatient care during the period?
No, there was a similar reduction in admissions and bed occupancy, and again, that seems to have normalised.
Have there been steps or measures taken to prevent COVID from entering into mental health inpatient wards?
Yes, that's a rather complex answer. One of the things which happened across the whole of health at the beginning of March was the restructuring of our operations, which is what happens whenever there's a pending disaster, and so the operations centre moved to Homebush, and there was an establishment of a Public Health Emergency Operations Centre, the FEOC, which is run through Kerry Chant, the Chief Medical Officer, and that really deals with all the public health issues. On the operational side, there's the State Health Emergency Operations Centre, the SHEOC, which was run by one of the Deputy Secretaries, Susan Pearce, and that really looks after the operational requirements, which is what your question is referring to. Mental health has a presence, the mental health branch had a presence in the SHEOC and has a connection back to the mental health branch and to my position. Simultaneously, we did something which is a novel thing, an innovation, which is the creation of communities of practice across the whole of health, and that's 30 different clinical streams, and including a mental health stream, which I co-chair with another senior psychiatrist, and that group. The community of practice was in order to quickly identify clinical challenges and quickly achieve a consensus on what those challenges meant and how we should respond to them. The membership of that group was all the directors and all the clinical directors for mental health services across the state, because we were very conscious that we needed to make sure that what was being worked on in one district was also known about in another district, because there's often lessons to be learned from different parts of the system. We also have a mental health pandemic response plan, and that's very similar to the disaster response plan. And one of the fundamentals in a pandemic response is to have contingency plans for what to do in the event that infection occurs in your community and even infection in amongst your patients and in your facilities. What to do if that happens, and what to do to try and prevent that happening. And so every district has a pandemic response plan, and we had every district submit those plans to our community of practice, and we put them on a SharePoint so they could all see each other's plans. Again, for the purposes of complete transparency and also the potential for learning between the districts. And the issue that you're touching on here at the heart of this, which is about doing everything that we possibly can to minimise the risk of infection getting into our inpatient services, is probably the issue that caused the most focus amongst all of our services during those 2 to 3 week period in March. There was a very, very high level of anxiety to make sure that we do everything we possibly can, learn everything we possibly can from what was happening overseas, and also to rapidly share what the solutions might be. So there's a much stronger alliance between the mental health services and the public health and infectious diseases services at a local level. And some of the issues are really quite straightforward. There's obviously screening is important. And then there's the use of personal protective equipment in situations where there could be the risk of infection. And there's also we had to develop some restrictions on both visiting and leave for inpatients. Now that is in mental health services, that's a really, really challenging and fraught issue to consider because, as you well know, when someone is admitted to an inpatient unit, what we try and do is to help them get to a position where they can normalise their life as quickly as possible, which includes going back out into the community. However, when you've got concerns that there's an exposure to infection by someone going out into the community, you've then got to factor in that if a person inadvertently is exposed on a period of leave and inadvertently brings that back into an inpatient unit, that's catastrophic.
Can I ask a specific question about this? Because all of that's very, very useful, but I have a particular question about what I think was a directive from Health in relation to and correct me if I get the language wrong, but I think these are described as leave, which I understand, or breaks, which I understand to be about people leaving, also visitors coming in. But my specific question is in relation to restrictions placed on patients in care. So, for example, cigarette breaks. Was there a policy in relation to restricting patients? And I understand the need to stop COVID from getting into these facilities. But why, if this policy is correct, why was it put in place? Were there less staff in place? Why couldn't patients go and have cigarette breaks when they wanted to? And
Okay, so
if you like, I can get straight to the point because I'm going to run out of time. I'm particularly interested, I don't expect there to be a discussion about the incident at Liverpool Hospital, but I would like to, I want to get an understanding of the policy that was in place.
Okay.
In relation to breaks or leave, if that's the correct terminology.
During COVID? Was the
Correct.
question confined
It's a
to the
policy
COVID
that was
period?
specifically related to COVID.
Thank you.
Not the patient that you're talking about.
I'm talking about the policy and
That's fine, I'm just clarifying.
So the only policy is the no smoking policy. So New South Wales health facilities are all no smoking environments. That's the policy. And that's a policy which has been in place for a number of years. And it's a very challenging policy to remain true to in mental health inpatient services. And there's a whole complex of literature and understanding behind how we best do that. So the concept of smoking breaks is not one that I endorse, but
can I just cut? But I accept that, and I don't want to cut you off. But I want to get to my specific question here. I fully understand and appreciate that health has a no smoking policy across the board, and that's a policy that's been in place for quite a long time. I get that. I'm not talking about that. I'm asking about a specific policy that was put in place across health certainly in inpatient care in relation to what patients could or couldn't do in terms of taking breaks.
So that's not a policy. So what actually happened is that one of the very early issues that was discussed in the community of practice, and again, it is difficult for us because so much has changed to remember what the thinking was in the middle of March. But the thinking in the middle of March was that we are about to be overwhelmed in the community and in our hospital system by the pandemic, and that our major concern, and this is a really serious concern, is that if infection gets into our units, we will be unable to provide continuity of care, and that is a catastrophe. So that's what we are trying to avoid. At the community of practice, the purpose of the community of practice is to identify issues and then to use the intelligence and the experience in that community to develop consensus. And the issue was some districts, based on what was happening in their facilities, generally, not just in the mental health units, had already made a decision because they had concerns about the level of community infection in their districts. For instance, the eastern suburbs of Sydney. They'd made a decision to suspend all leave. And so it naturally came up at the community of practice, what's everyone else doing? And so we had a conversation about, well, why are you suspending the leave? Because that's going to have consequences for some patients and for their families. And they said, because we have this major concern and we believe this is the absolute priority is to prevent infection getting into our units. And the consensus was easy. That has to be our major concern. in suspending leave, what that then did. And so what we did was we wrote a memo and we said it was advice. And so we did not say that was mandatory. It was an advice to the system that this is the consensus is that preserving the integrity of inpatient units and preventing infection getting into those units should be seen as an absolute priority. I still believe that to be the case, and I would return to that perspective if we had significant community virus at any point in time. What that exposed was that in some facilities there was a workaround to the no smoking policy, which was to provide people with periods of leave in order to allow them to satisfy their need for a cigarette. However, there's also a very strong national and international literature which says that if you properly address someone's nicotine dependence at the point of admission, you can eliminate the need for them to have to have cigarette breaks, and so so the use of smoking breaks is not universal, and also the implementation of good consistent practice around nicotine replacement is also not universal. It became a serious issue to address.
So I don't want to cut you off. I'm just conscious of.
We'll let Dr. Wright finish, and then you'll be
Because
in my
otherwise
time.
I'll just wrap it up. But I just want to get a
we'll let Dr.
clarification.
Wright finish, and then I'm more than happy to use a small part of my time, which I otherwise won't use if you have any follow-ons.
Well, what I can do to
let's let
wrap
Dr.
this
Wright
up is
finish.
if the committee can be provided with a copy of the memo or the policy or however you want to describe it, then that would assist.
Advice,
So there's been
described.
3 memos,
Can we get a copy of all of them, please?
and the current memo, so each one supplants the previous one. This is a moving target. The current memo basically says
Formally
that
request this,
each district mental health service ought to be liaising closely with their local infectious diseases and infection control experts to identify what is the current risk in their community of the virus and adapting their leave according to that. So the initial one is no longer in place.
Yeah, I understand,
but-
Minister. So the request is, can the
I'll take that
iterations
on
be
notice.
provided?
Yeah, we'll
Yep.
take that on notice.
Thank you. Any final question, Tara?
No, but I'd like to have a discussion about how we formally deal with that at some point. But go for
Well,
it.
no, it's been
I just don't.
been
A
addressed.
genuine question because I don't know.
No,
but
it's been
that's-
addressed. The Minister said she'll take it on notice and we'll provide them. Did you say you'll provide them on notice?
I said that
Minister?
I'd take it on notice and have a look,
With-
and if they're public, I mean, I think it's just.
That's my
yeah,
question.
Yeah, absolutely. It's
Well,
just
they're
the,
GIP reports.
Sorry.
Policy.
Yeah,
I
but
don't know.
No.
that's
but
fine,
we're
Mr.
trying to
Should we-
avoid going through the GIPA process. If they could be provided
Should we
as soon as
please-
possible, that would be
yes,
appreciated.
they will be provided as
Minister.
soon as possible. If there is any delay or any reason why we have to question that, then I will come directly back to
Thanks,
the committee.
Minister.
We don't foresee that, and we should be able to provide that in a very timely manner.
Sorry, not trying to cause trouble. I just don't know. So just check in.
No. Can I say, Minister, we're grateful for the cooperation, and but I think the time has concluded.
Yes.
Unless you had any final questions, Tara. Minister, I know you'd like to stay with us for longer, but unfortunately, the questions from the opposition and the crossbench have concluded. But there is an opportunity for the government now to ask some questions.
No.
Ms.
You don't speak for me, Mr. Khan.
Trevor, it's nice to see you back.
Having absented
The
yourself.
Honourable Natalie Ward.
Thank you, Chair. I just wanted to, on behalf of the government members, thank Minister Taylor and in particular Mr. Pearce and Mr. Wright, Dr. Wright, I apologise, and all of your teams for the incredible work that you've done. I accept it's more of a statement than a question. I thank the Chair for his indulgence, but these are extremely difficult times, and your responses and incredible work, I'm sure this was not what you envisaged you signed up for, but we're very appreciative of the commitment you've made to the people of New South Wales and your work during this time. Thank you.
Thank you.
All right. Well, that does conclude the hearing. Minister, again, thank you for your attendance and cooperation today. Dr. Wright, Mr. Pearce, again, thank you for your attendance today and the work you do. There were some questions taken on notice and the commitment to provide some documents on notice. There's a maximum period of 21 days for those responses. So
Mr.
thank you,
Shoebridge,
Minister.
I will try and reduce that maximum with all of my ability for
Thanks,
you.
Minister. And that concludes the hearings. We will be returning at